Welcome back to the new episode of the Glow Beyond podcast, where we learn how to live better with skin condition. Today, I have a very special friend with us here. So his name is Dominic, and I've known Dominic for a while now, actually, since 2019, if I'm not mistaken. And Dominic is someone very, very warm, always very proactive in advocating for himself and also for the psoriasis community. He is an active volunteer in the Psoriasis Association of Malaysia and also for Psoriatic Arthritis Association. And he's also a very excellent patient advocate. So let's welcome Dominic.
Hi.
Feeling?
Good. You can just call me Dom. That's what
Okay.
people call me. Yeah.
All right, I'll call you Dom.
Yeah.
So, are you feeling all right today?
Good. Yeah. Just a normal day in a work week, and
And
good.
you're being forced to be here to talk to me about psoriatic arthritis.
That's okay.
All right, so Dom, tell us a little bit about your journey with psoriasis.
Okay. So it goes way back. About 20 years ago, I was just working like everyone one day in the office, and then I started to spot some red dots, and I thought it was a rash.
How old were you back then?
In my mid 20s
Mid-
to late 20s, yeah, mid 20s, yeah. So I'm in my 40s range now, so that's 20 years ago. Went back home, just put some cream on it. Next thing you know, there are more spots coming out, and I just went to see a doctor, and the doctor just said that, hey, this looks like psoriasis, and I was like, never heard of the word, and then 20 years later, here we are. Yeah.
Back then, when it started, was it very intense suddenly? Like it just break out suddenly, or it was just
No, it was just probably appearing at different parts of my body, but it was more of guttate. So guttate psoriasis, and there are many types of psoriasis. It's like raindrops. So it was like drops. Not everywhere, but there were drops. But over the months, those drops, some of them merged, some of them got bigger. And over the months, then it became plaque plus guttate. Yeah. And guttate psoriasis is basically quite well known that it's half gene, half trigger. So I did remember catching a very bad sore throat, which technically could have been the trigger, and then your genes express themselves, and yeah, like they say, 10% of a country's population has psoriasis, but only 2 to 3% will manifest.
I see. So,
Yep.
so meaning that I can have the gene in my body,
Yes.
but because it's not triggered, so it's just lay
Yes. So
express itself.
yeah, so it's not just gene, it's many genes. And I don't speak with authority, but I just speak as a patient advocate or a knowledgeable patient who reads up on these things. So yeah, from what I know and from what I read, it's that way. So I'll give you an example. My dad probably also has the genes. For 75 years of his life, he has not had psoriasis, although he has other autoimmune correction. He has maybe immune related, such as asthma, but the psoriasis only manifested as scalp psoriasis when he was 75. Yeah.
Oh, 75.
Yeah.
So he skipped all those
Just give all the
early
years. Yes. Yeah. But he's starting with scalp psoriasis, which is also not easy to control. Yeah. And he only has scalp psoriasis and a few other patches, but that's it. Yeah.
I see.
Yeah.
So today we actually want to talk a little bit more about psoriatic arthritis. So do you mind sharing with us how did the development of psoriasis to psoriatic arthritis happen for you, and how long it took, and how does it look like?
Sure. So basically, psoriatic arthritis, it's not as easy to diagnose, although of course we have rheumatologists who can diagnose it. Why I say it's not so easy is because I'll get to that part. So I think symptoms will appear. Just pause about myself first. I just wanted to say something, which is actually a lot of people who have psoriatic arthritis don't get diagnosed until maybe months or years, because depending on who they see, the symptoms are not sort of like a bit generic. So let's say now I'll come back to myself. I've always had the on the back of my mind that, we all know that about 3 out of 10 or 4 out of 10 psoriatic patients will get psoriatic arthritis. So that most of us live our lives and say, oh, could I be the one? And then you just say, hope not, or
It's
pray
very
not. Yeah. So I was in a job with an NGO back in about 2018 and working very hard. And I noticed that my energy levels were depleting and I was experiencing more fatigue. Technically, I have been experiencing fatigue through my life, but it's always because I've been working very hard at my volunteer work and office work, but this was very different. It was to a stage one day. I remember I was in the office just sitting like here with you, and I was with some colleagues talking about work, and I felt as if like someone had pulled the plug in the sink, and I could feel my energy levels just drop very rapidly. And I said, okay, there's something wrong here. It's not very normal that I can just suddenly feel that kind of fatigue, where it's a very draining kind of fatigue. And so, long story short, I saw the dermatologist. I said, could it be PSA? But I don't have any pain yet. And they said, dermatologist said, yeah, why not just go see a rheumatologist just to see what they say. Rheumatologist saw me. Roy, I'm not sure about you, but you or may other patients may have noticed that for those of us with psoriasis, some of us have nail pitting.
Yes.
Yeah, that's where the psoriasis. I've always had nail pitting from day one when I've had psoriasis. And rheumatologists already say, hey, I see you have nail pitting. That actually gives you, I think, something like one out of, I think she has, I can't remember, but it roughly goes like this. She probably has about 10 points scoring. The nail pitting gives you like immediately 4 or 5, and then checking whether you have pain. While you're at the rheumatologist's place, they would do the physical examination to press. But I hadn't had any pain. All I had was the very bad nail pitting and the fatigue. So, as with most patients listening to this podcast right now, and if you are a psoriasis patient, and if you please Google up some symptoms if you feel that you have more than just skin. There's the usual fatigue, there's the pain, there's the brain fog. All these are quite common, and then there could be others. What I wanted to say was that bring these symptoms to the doctor, but I'm quite sure that good doctors will also want to rule out other conditions, but they may also in the back of the mind not tell you, but some may tell to say that, look, you could have comorbidities as well. So example, some of the other conditions that I was asked to look for would be check thyroid, full blood tests. And then another one was because fatigue is considered a very general symptom, it's very hard to diagnose. Example, if you have depression, if you have had friends with depression, I think many of them would say they're tired as well. So you have to rule that out, whether the patient is suffering from depression, and you could be suffering from depression because of psoriasis, right?
Yeah.
So cut long story short again, I went through the thyroid, everything was okay, blood check okay, heart was okay. Then came check whether you have sleep apnea. And I was like, I'm not overweight. And so I discovered that I had sleep apnea for someone. In some literature, sleep apnea is also a comorbidity of psoriasis.
Can you tell us a bit more about sleep apnea?
Yeah.
I've never heard of it before.
Yeah, okay, sleep apnea. Okay, so basically between your mouth and your nose, where you breathe, all the way down to your lungs, something could be causing you not to get enough oxygen while you're sleeping. Example could be that while you're asleep, okay, so some people may have a bit of more weight, and let's say when you're sleeping, because you're either older or more weight, some of the parts of your airway could be looser, and then when you relax, they kind of constrict, and your airway becomes more narrow. So it could be anything from maybe where your intake is from your nose start to get narrow. But what basically, and I speak in very simple terms, is that while you're sleeping, you're not getting enough oxygen. Okay. And then your brain could be saying, wake up, wake up. So then your body's trying to get oxygen, right? Brain's trying to wake you, but you're also trying to sleep. Brain's also trying to balance that, mechanism. And therefore, you don't get a good regenerative sleep and you wake up really tired. So cut long story short, the gold standard is to sleep with the CPAP machine, continuous pressure. I can't remember what the CPAP is, but you sleep with the CPAP and it gives you enough pressure to open your airways. I tried that trip.
Like it's life-threatening.
You can lead to stroke if you don't. So there are three phases of sleep apnea. One is mild, moderate, and severe. If you have severe sleep apnea and you don't treat it, it can lead to stroke, which is not what we don't want. But long story short, and we're coming back to psoriasis, I don't want to spend too much time on the sleep apnea, was that I have an issue where, have you choked on water before?
Yeah.
Yeah, you have,
It's
right?
a very normal thing.
Yeah,
Yeah.
because it goes into the wrong place, right?
I took out my own saliva also.
Yeah, so basically there's something called the epiglottis which closes when you drink water. So mine, when I sleep at night and if I lie on my back, my epiglottis also closes, so not enough air goes into my lungs.
Okay.
Yeah, so I'm seeing a sleep dentist, and not many people have heard of sleep dentists to actually help you, for instance, open your airway with a mouth device when you sleep, and then they monitor you over time just to make sure that and that's actually a measurement for. There are devices to measure your sleep apnea, especially they call it the AHA, apnea hypopnea index. We won't go into that, but yeah, I'm okay right now with the treatment. Yeah.
I see.
Yeah.
Right. So we are coming back to psoriatic arthritis.
Yes.
Can you help us understand a little bit about comorbidities?
Yeah, I was just going to say that. So, like I said earlier, a good doctor would actually. Okay, so if you present yourself with something like fatigue or brain fog, they would have to check other things. And that is an example of where you may veer off and you may find a comorbidity like myself. So when we talk about comorbidities, basically, this was actually quite, how I say, insightful for me. Even though I had psoriasis for about 20 years before this diagnosis, I was checking for other comorbidities. Comorbidities being that you don't only have psoriasis, you actually have other illnesses as well. So I found it very easy as a patient to understand when I walked into the immunologist room one day, which was, I was just checking during my tour before I was going to go back to the rheumatologist, because rheumatologist said, please go check with all the other doctors. Once you finish, come back to me and tell me what's going on. And the immunologist told me, she said, hey, you have autoimmune disease, right? I said, yeah, I have psoriasis. All I know is autoimmune or autoimmune mediated, depending on what literature you read. And then he explained to you, well, just let me give you a simple explanation about autoimmune disease. It's basically anybody who has a dysfunctional immune system and it attacks your organs. So for you, psoriasis, it starts with the skin. For people like, for instance, RA, it goes immediately to the joints. For lupus, it can be anywhere, but it'll attack your organs. So it may start with the skin and then it'll go to affect your other organs. So to me, that was like, wow, actually, 20 years, I never really got that explanation, and thank you. So I kind of understand. So that was a very simple explanation of what a comorbidity is. So for us, psoriatic patients, I've read literature that says PSA is a comorbidity. Ultimately it's semantics, right? So you still get it. So what I'm just trying to say is that heart issues could be one, because the inflammation will start affecting the heart. Or we've known some friends in the arthritis side. Have you seen friends with like really red eyes, like as if they got infected?
No, actually.
Yeah, so it's called uveitis, and people with psoriatic arthritis or psoriasis can get it. So basically, inflammation travels to the eyes. Yeah.
Wow, I never knew that actually.
Yeah, so that's an example of a comorbidity. So I think for those who are listening in and you want to find out what a comorbidity could be for a psoriasis patient, just go to a reputable medical website and Google comorbidities for psoriasis, and there's a list. I think the list that I use would be on the Psoriasis Foundation of USA. Actually, even I would like to say that you don't have to go so far. So as a volunteer, I helped with setting up the new the Psoriasis Association of Malaysia website. We've actually listed the comorbidities there. Yeah.
Okay. So I would say, like, learning from Dom, as a patient ourselves, it's very important for us to be aware really like what's going on inside our body. So it's very important for us to practice the awareness and keep observing our body and our conditions so that we can communicate to our healthcare provider also. So please do that. All right, so Dom, can you also share a little bit about what are the early onset symptoms that you face? So you mentioned about fatigue, right?
Yeah.
And you mentioned about what else you mentioned? You've mentioned about fatigue.
Yeah, fatigue. And then
Pain.
yeah, the pain actually came later. So it was after I saw the rheumatologist. Rheumatologist says, do you have pain? I said, no. And then after 2 months after I saw her, then I was like, darn it, the pain's starting. So it doesn't come together. Yeah.
How did it start?
Okay, so definitely there was a lot of lower back pain. And then that lower back pain started to get not only acute pain. Some days it was acute, then started to experience like a broadening part of the pain, and then I started to feel the stiffness. Like it just feels that you're no longer flexible, and like when you sit, it's not comfortable. Yeah. So anybody who's had a backache would have felt that, but that backache just doesn't go away. Yeah.
I see.
Yeah.
So you had that, how old were you back?
Well, just 2 years ago. So it's just my mid 40s. I started feeling that back pain. Yeah.
Okay, so before you had the pain on your back,
Yep.
you were dealing with extensive areas of psoriasis.
Yeah, just psoriasis cover, but I wouldn't say extensive because I was probably on 8 years on acetaminophen, which is just basically takes care of the skin, but I will need to check with the rheumatologist whether or dermatologist whether it actually takes care of the inflammation.
I see.
Which in the case of one, which is me, I took acetaminophen for 8 years just to minimize the flare and the psoriatic skin areas, but I got PSA, so I technically from reading online, I don't think acetaminophen takes care of inflammation or on your possibility of your road towards PSA. I don't think it does. Versus, let's say, if someone was to take biologics, let's say you have psoriasis, you take biologics. I think there is emerging literature that says it could possibly stop you from developing even PSA, but the cost is very prohibitive.
Yeah.
And so I think not many people take that as a prevention. And I don't think that we need to check this with the rheumatologist or dermatologist, but I don't think it is yet a protocol to say start biologics for prevention of PSA. But I know that there are a lot of researchers that have started to postulate that idea. Yeah.
Okay. A lot of people who are listening to this, we actually have psoriasis, and living with psoriasis, we also live with the fear and anxiety of the possibility of it developing into psoriatic arthritis, right? So you also mentioned that not everybody will get psoriatic arthritis. So
Right, yep.
can you help us understand what are the triggers for psoriatic arthritis, if there is any?
Yeah, I'm not familiar with triggers. I'm more familiar with symptoms. We've talked a bit about prevention, that you really have to discuss with your dermatologist and rheumatologist about prevention. I think I won't go into that, but it's basically your decision to say like, look, I really have pitted nails. Maybe I'll talk a bit about the complexity of the prevention and also the symptoms.
Yes.
Yeah, I think the complexity is what
Can be confusing a lot.
can be confusing to patients, and I don't think that there's also a straightforward answer from the medical specialist, and that's why I feel that patients should be well informed. I mean, there's always this chicken and egg. You're probably very busy with your life. You're probably working very hard to take care of your psoriasis, and you're like, if I get psoriatic arthritis, I'll deal with it then, right? But there's also the case of like, if you don't know what you don't know and suddenly you start having symptoms, then it may be, people will say, was there anything I can do to have prevented this?
Like I can see it coming,
Yeah.
see it coming. Then what I can do now?
Okay, it's not easy. So I'll talk about the complexity is, from what I know and what I read, there's psoriatic arthritis presents itself in radiographic and non-radiographic. So what does radiographic mean? In very simple terms, it just basically means whether, let's say, you go for imaging, and imaging could be X-ray, MRI, whether it presents itself. And if you don't have radiographic, and if you do have the symptoms, let's say the pitted nails, the pain, that maybe if you have a rheumatologist on your show one day, you can ask them how do they diagnose a non-radiographic patient, which I believe that it actually exists. So back to the easier part, which is radiographic. So Rogi, the difficult part today about psoriatic arthritis is that we don't have a biomarker for it. A biomarker means that I do a blood test, there's something, let's say, called X determinant, which is the psoriatic arthritis. Actually, the Psoriasis Foundation of USA are putting money in to develop a biomarker. Give you an example, for other arthritis patients who have inflammation, they have things like C-reactive protein, which is basically also part of the blood test. They can find out whether that is high or low, and that tells you. So for my case, my C-reactive protein was low. I remember there was another marker that was also low, but I was having fatigue and pain. So the doctor also did his medical examination, and I'm still talking about complexities, using me as an example. He was, doing all the physical checks, prodding here and there. I said, do you have pain? I said, I have general pain, but where you're prodding, it's not painful where you're pushing your fingers as part of the examination. So he says, I don't seem to be able to find. So, I mean, I'm guessing that in my rheumatologist's mind, he was thinking, maybe this is a non-radiographic. But I was quite persistent. I said, doctor, let's do x-rays. So he did the x-rays and he says, usually we find it at the sacroiliac joints. Yours, we did the x-ray, couldn't find it. I said, no, doc, I'm still really thinking that there's something wrong here. So I really pushed him hard, and then he said, okay, well, why not? Let's keep on doing imaging. Let's try MRI of yours. I think MRI or somewhere else, and then still couldn't find my backbone. I think then it was an x-ray of the spine. Then he said, oops, after that radiograph, radiologist says, came out report spotted on my, not mistaken, it's like if you go for this, chiropractor, right? They always say it's the cervical, the lumbar, the thorax, and then spots it close to my neck, the C2 and 3. So back to complexity, right? I think you've seen my story. It's not easy to diagnose.
Yes.
Yeah. Okay. It's easier where, have you had friends who have PSA and they've said, Rocky, I've got fingers that look like sausages?
Yes.
Yeah.
Fingers are swelling.
Yeah. So fingers or toes. So I'll just use the term sausage fingers. That's quite clear for a doctor to say, hey, you've got psoriasis, you've got pit nails, you've got sausage fingers. If you want, we can just check for imaging as well, and then we will see whether we can find something. So that's clear cut. Some patients like me, not clear cut, no, but you have to go all the way to imaging, and sometimes you got to image all over until you find it. Yeah. So come back to the complexity. One, the diagnosis can take some time.
Yeah.
Two, prevention. I don't think the medical space has got, or the medical profession has got to the stage where they say, just take biologics for X number of years, you are on a trajectory to PSA. Maybe one day, if there is a biomarker that says it looks like you have PSA, you don't have the manifestations yet. Now, Rocky, I give you a decision. The risk seems high. You may want to consider biologics as a prevention, but I don't think we're there. So again, this topic, I'm just speaking as a patient from just reading literature. One day, maybe if you interview dermatologists or rheumatologists, you can bring up this topic again.
Yeah. Okay, so I want to go back to your journey when you mentioned just now, and I also want to kind of raise awareness for actually patients speaking up for ourselves.
Sure.
Because when you went through the journey of testing, multiple tests, to find out whether or not you have psoriatic arthritis, the tests were not showing exactly what you needed to know. And yet, because you yourself know that there's really something wrong inside you, so you insisted to go on with the test. And I think a lot of the patients out there will not do this because we always place 100% authority to the doctors. But I would like to also raise the conversation of, the doctors may not have 100% understanding of what our situation is also. So as patients ourselves, we really need to really put in the effort and also being more proactive in really knowing us and our condition and the progression of it, pay a little bit more attention, and also just be more aware really of what really is going on with our body. So thank you for sharing your journey when it comes to that. Can you share a little bit about your treatment journey since the beginning of your days with psoriasis and also into psoriatic arthritis? How did it look like?
Okay. I think when one starts off, unless you're having, for myself, right? So I'll just say that mine was just cutate, and it was a stage whereby doctors would just prescribe topical creams. So that's fine.
It wasn't so bad, right? Okay.
Yeah, at the starting wasn't bad. Then, as time goes on, the surface cover of your body gets more and more psoriatic patches. And then, of course, I think most patients, without a doubt, would be once it starts appearing at hands and face, then you feel that you need to have a bit more control because it starts getting uncomfortable when a lot of people ask you, are you having a rash? Are you allergic to something? So when we got to that phase, and then the scalp psoriasis is the one that I think a lot of people also start getting really uncomfortable, because
Yes.
I'm sure you've experienced scalp psoriasis before.
Yes.
Yeah.
I still have it.
Yeah, when it's the plaques starting to get very thick on your hair, it gets really uncomfortable.
It feels like you're wearing a invisible helmet on your
Yeah,
head.
and then you just want to, sometimes you scratch and then the flakes start coming
all
off.
over
Yeah.
the clothes.
So that's when I said, hey, doc, you gotta give me something more to control. And then there was the years of acetylcholine, more suited for male than female, because especially we have patients who are of childbearing years. They want to, and that's not very good to have acetylcholine. So it was easier for me to make that decision. And then, yeah, it was just basically acetylcholine and topical for many, many years until the pain fatigue started. And then it was to biologics. Yeah.
Tell us a little bit about biologics. Actually, what is biologics in your term?
Yeah, I'll try to make it become very, very simple. So maybe cue the visual aid.
Yes, you brought it today.
So example, this is one of the later ones. I think most patients should learn this word called interleukin. And why I say that is because actually biologics, if you see here, and if I can find it on the box, if it's not here, no worries. It's probably on the literature. You will see something called, and if you read online, at least for this brand, Tremfya, which is guselkumab, it's an interleukin inhibitor. With most biologics, a lot of them are interleukin inhibitors. We just have to learn the word interleukin. It sounds very foreign word, but interleukin just basically, in very, very simple sense, as a patient, yeah, I'm sure other dermatologists will give you a better definition. There are signals in terms of chemicals that get sent from our cells. So the interleukin inhibitor basically short circuits that signal, and therefore you don't have your inflammation. Therefore, no psoriasis, skin issues, inflammation, and no damage to your joints, because the process is not happening.
Yeah. So according to what I understand also, biologics is basically it cuts off the communication of inflammation.
Yes, that's a good word. Yeah.
Yeah, from coming out on top of our skin and our joints. So basically, it just cut off lah.
Yeah.
So that's what biologics is able to do for people like us. So I think a lot of people are aware about the treatment of biologics, and it's basically something that we all want it because it's just so simple. You just get a few injections, and then we have clear skin, and then we are off joint pain as well. But the issue is also the cost.
Yeah, that's true.
Do you mind sharing how much you're spending on biologics every year?
Okay. So before we get there, I'll just and just want to dovetail on what you said about being very easy. So this is like injectable pen. And it's already used because I've just injected it 2 weeks ago. Basically, it's quite longer. And also, it's very easy now for you to inject. I mean, it used to come in needles where either you're brave enough or you can inject yourself, or you ask a friend or a doctor. But now with this one, you just have to take off the cap. There's a needle in there. You just press it against, let's say for me, I press it near my navel, and then I finish off with it. And I just, dispose of it responsibly. So you just keep this in the fridge, and when you're ready to inject, for me, it's every 8 weeks, and that's done. So back to the cost. Yes, it's very expensive. I'll straight jump to the cost to say that it can range anywhere from maybe, this is a ballpark figure, very ballpark, 25,000 to 50,000, depending on the biologic you're using. There's, I think, more than at least 6 to 10 out there for Malaysians, starting from the first generation ones to later ones where it was, interleukins go by numbers, right? So there are interleukin 17 inhibitors. This one's an interleukin 23 inhibitor. And so that's the rough cost. But to talk a bit more about cost and access to this, as in, if, let's say, depending on your income level, if your income level is not as high, and we just use the term here for technicality purposes, we're not looking down on anyone, but should you fall into, let's say, B40 range, you could potentially look for the tabung bantuan, which a doctor will need to help you get on. Or for our Muslim friends, you could try zakat. to get it.
There's also patient assistance program.
Yes, yes. So patient assistance program, I actually had tried it as well. What you do is that you approach a pharmaceutical company. So let's say, example, Tremfya is by Janssen, Novartis does, if I'm not mistaken, Consentix, yeah?
Yes.
So you just approach them and you say, I would like to inquire about the patient assistance program. You submit your some documents, including your payslip,
Yeah.
and then they will work out a price for you and you present to you, and then you will see whether you can afford it. Yeah.
So, the patient assistance program,
Yep.
do you know how long it lasts actually? Because actually, one of the reasons why people, like it really prevents people from getting biologics is also because when I when I have access to this
Yes.
treatment,
Yes.
then I am worried about, okay, for example, my patient assistance program is only going to be able to cover 1 to 2 years.
Right.
And I would keep asking myself, what happens after that?
Yeah. So from what I know, my personal experience was I applied for it. I got it for a year. So first I was taking Tremfya. I went on Consentix just to see what's the efficacy level. They gave me a year, and I asked the same question: what will happen after the year is up? They said we will just basically go through the process again. I didn't go through the second year process, so I'm not sure whether it was resubmission of documents, which I think so, because they want to see whether your salary has increased or. And then you evaluate from there, and if let's say more or less, I think if you're more or less in the same income bracket, they will likely continue.
Okay.
Yeah.
Right. Thank you so much, Dom, for sharing your treatment journey and all this information with us. I believe that even myself and also a lot of people who are listening to this, we are actually learning a lot from you. And it's so crazy that you know so much. And it's something I really admire about you because it's something that you do. You did all this research and all this reading in order to help yourself to become more informed. And being an informed patient in this era of time, I believe is really, really important because it helps you to communicate with your health care provider. So that's that. So back to you, Dom. I just want to understand a little bit more about your journey.
Yep.
There's a question from my Instagram that's actually asking, I didn't know actually you're a father.
Yes. Yes.
Has psoriasis affected your decision to become a father, to have kids, to have children?
Okay. Every individual make different decisions. I know that some folks who have psoriasis, they still have maybe 2, 3 kids or maybe 4. For my family, we decided, Kaylee is my daughter. We would have one child, and then we weren't really sure whether we wanted another one. But I also developed psoriatic arthritis later on, and always in the back of my mind was that because it's genetic, right? I can say that, just to share with the audience, on my dad's side, every one person on my dad's side of the family has autoimmune disease, but not everybody has psoriasis.
Oh, so the manifestation of autoimmune condition is different.
Yeah. So my sister has a different kind of autoimmune disease. My auntie has a different kind. My first cousin has psoriatic arthritis, but not really sure whether it is psoriatic arthritis, but it is, it's proven via x-ray, but hers is just under the umbrella of another big word is spondyloarthritis, which is psoriasis affecting the spine. So there's umbrella term. PSA fits under the umbrella. So back to my daughter would be, we are concerned that one day she will have autoimmune. Of course, we do save up. We're trying to save up a bit of tabung so that we can help her if she does. And I think it's really an individual's choice whether you will want children and what's the sort of like the word is gamble, right? What's the gamble of having? But having said that, I would like to say that as a parent, there are many dimensions of being a parent that you cannot know until you become a parent. So the joy that my wife, me, and my daughter Kaylee has experienced since being a very small and tight-knit family is the love is beyond the love that you feel for your child and for my wife, and it's beyond goal. Yeah, it's beyond measurement, and it's just been really, a real blessing and gratitude that I cannot measure.
Thank you for sharing this because even personally for me myself, psoriasis has been a huge factor of me, like it really affected my perceptions and also my expectation of being a parent, especially when I'm in my 30s now.
Sure.
There's a lot of fear and anxiety around it, and I think conversations like this are very, very much needed. So thank you so much for sharing your story. So, living with psoriasis and psoriatic arthritis, right, in the earlier days of your life, early 20s and 30s, how did you actually manage your work-life balance dealing with a skin condition?
Yeah. So I think most of us after a while learn the tricks of the trade, which is basically, long sleeve. When you're working in the office, don't wear dark clothes. Always wear your whole wardrobe is probably something very light. When you're working in your office chair, because you will have flakes, you will put the maybe a jacket that's light color, so it takes a bit of flakes. Every once a week, when you stay a bit later, when colleagues go out, and you clear all your flakes. Yeah.
Do you bring vacuum to office?
No. But I mean, we've had some colleagues who have been a bit curious or a bit, hey, say Dom, I think it's a stressful period. I see you scratching more often than not. So okay, I say thank you very much. Some other colleagues also have been very, very helpful. They know that I think many of us go on a low inflammatory diet. We kind of over the years know what causes inflammation, and so we just try to do our best to have a diet. Yeah. And when we're going out with colleagues, it'll be like if you're going for drinks after work, then I'm like, oh sorry, I just can't do it because I can't do alcohol. It just causes so much inflammation. I've actually tried before just to take the alcohol, but yeah, just so much inflammation, then you're like, no, it's just not worth it. Because it's not I don't want to drink, just like I can't because there's so much inflammation. And then I'm sure your other guests would have spoken about it as well.
Yeah. So can you also share a little bit about how did psoriasis affect you as a man? If there is any.
Yeah, I was quite lucky that my wife was very accepting. At that time, we were still going out. So at the time, then we got engaged, we got married. So as a man, right? Basically, there are some things I just won't be able to do, like can't go for drinks. But I'm not a heavy drinker myself. Self-esteem wise, if you're having a flare, I think it does affect self-esteem, especially if you're in a leadership position in an organization. I'm not talking about like a workplace, and if you're having a flare, and if you're in having just psoriasis skin, if you're flaking a lot and all, it does affect those things.
How did you navigate that, being a leadership position and
I just tried very hard, and I have very understanding colleagues and also understanding bosses, so I was in a good place. But that's just for me. I'm sure there are other people who are in positions or situations where it's not so easy. I think I just maybe not talking about being a man, but it's both genders, either a man, a woman, or non-binary. I think when you get into the PAC stage, it can actually be a bit more challenging because now we're not only talking about skin. I mean, if you can get yourself, worst case scenario, you don't have any medicine, you can't get on a treatment, or if you get on biologics are not silver bullets, it can start to fail. For example, would be I've been on this treatment for 3 years, some patches are starting to come back.
I see.
Yeah.
Okay.
Yeah, so but they're on the scalp and they're very small. So I will just use, and of course, we do advise patients to join support groups, just as how you and I both are volunteers and help out at PAM, PAM being Psoriasis Association Malaysia. You can see some of our friends, they say, Dom might be on the biologics X years, not working as good anymore. Then the next thing to do is either switch, because good that we have many biologics now, we can switch to see whether the other one works, or in recent years, we may or may not get into this talk today, but we have also got now small molecules. They're in pill form. But the bad news is that the good news is that they do work. The bad news is almost same price as biologics.
Okay.
Yeah. All right.
No.
So also good news is that we have more options, including I know somebody who has said, hey, actually I'm on the pill form, the small molecules, the JAK inhibitors. Because these things, biologics, you have to store in the fridge, right? But the pills one, when you're going traveling, you can just bring them along.
It's easy.
Yeah, but I think you have to take it daily, if I'm not mistaken. But since this is 8 weeks, you inject,
But is it available yet?
It's available in Malaysia, and there are more coming, Yeah.
So how if I want it, how do I get it?
You will have to speak to your dermatologist and rheumatologist, yeah,
I mean,
depending.
is it available in a government hospital as well?
Even if biologics are available and JAK inhibitors, which are, if I'm pronouncing it correctly, Janus kinase inhibitors, which is also they're basically enzymes. Yeah, so it's also short-circuiting the enzymes. Yeah, so they are available, but at government hospitals, unless you're on some assistance program or tabung bantuan, you will still have to pay out of pocket at government hospitals because these are just too expensive. Yeah.
I see.
Yeah. So back to, I'd say, gender or non-gender, and back to coping with your symptoms. I think pain is one issue where. So can I ask you, have you ever had a toothache for many days?
Yes,
Yeah,
I did.
you have, right? So imagine that. I always use this as an example. Imagine that toothache, and with our computers we copy and paste, right? So you copy and paste. Imagine the toothache is here, here, here on your spine, and with that much of ache, and when you're trying to work,
It's very hard.
it's very hard to focus, right?
Yes.
And I've had gone through that period. So I think when you get PSA, the challenge, and if you have pain and uncontrollable pain, would be slightly more. I not the word is not slightly, but it's actually more challenging than just having skin without pain.
Of course.
The other thing would be if you develop brain fog, and maybe if you invite me on the show again, I can talk a bit more.
Yes, of course.
Yeah,
Welcome back.
just a very quick preview would be a lot of researchers are saying that the inflammation does travel to the brain,
Yes.
causing such things as brain fog, difficulty in focusing, and hence causing the sleep disruption, the non-generative sleep, and you're going to be finding it very difficult to focus on your work, especially if your work requires a lot of mental focus.
Yeah.
And then the third one would be the fatigue. Of course, the fatigue will be a blanket thing. It gets into not only your work life, but also gets into your personal life. So if you're a parent, you take care of a child. I'm sure it's not easy when you're feeling really tired, and it's quite. I think for most human beings, when you're tired, your mood gets affected.
Of course.
Yeah. So with your mood being at a low, or really we're talking about, then we're entering into the area of neurotransmitters. Yeah. Again, I'm not an expert, I just read, so maybe that topic is for another day. So back to having PSA and it's just a challenge. Depending on what your symptoms are, these symptoms could affect your work life and personal life.
Yes.
Yep.
And yeah, thank you so much for sharing all that you know.
Yep.
I've learned a lot from you, and it seems like, I mean, this is what we know. It's not just seems like, it's what we know. Having psoriasis is not easy, and having psoriatic arthritis, it definitely makes our life 100 times even more difficult. And the importance of having this kind of conversation is to let you know to, take charge and being more proactive in our own journey. And also, really important reminder for all of us is that, we always need to seek support, either from our doctors or from our friends, or even just listening to podcasts like this, learning more about our journey is very, very important. And yeah, it's a difficult journey.
Yes.
I'm really, really grateful that there are people like you who are so, proactive in learning and also so willing to share. So thank you so much, Dom. And we'll definitely have you back again.
Yep.
So before we end, I know
Yep.
something you want to say. So is there anything else you would like to say?
Yes, I would just have to say that don't lose hope. There is hope. I'll give you an example would be, I respond well to the biologics. I don't know whether I'll continue to respond to these biologics well in next few years, but at least for the past few years, I managed to stabilize my psoriatic arthritis by one. If you lower the inflammation, all the other symptoms that you face can be controlled.
Yeah.
So fatigue is something that I still can't control. There are some days that I get bad fatigue and some days that are good. But generally, it's much better. I have more good days than before I started biologics. So why I say one, be creative is, and that's story for another day. I actually now also work with neurologists for medication that is not prescribed by the rheumatologist and not prescribed by a dermatologist. And where I look for all these, I do check the website. I go on Facebook, I see what other people are doing, but I also check using AI, now with AI, and that's maybe a topic for another day, just to check a bit more background. And I actually make suggestions to my neurologist to say, I would like to try this. Yeah, and then I've managed to find a neurologist who's quite open. And she said, okay, you seem to know quite a lot. Why don't we give this a shot? And not only that, whatever she's prescribed, as per the pills taken, I start to get creative. I don't take it as per what she's prescribed, but I try and experiment here and there. But of course, I do tell her to say, I'm going to try this. I'm going to cut the pill in half. I'm going to, because it just the pill alone gives quite a lot of symptoms, but I cut the pill in half, and then yeah. So just give me an example of being creative, but don't be overly creative until please know your limits. There's some medicines that are not supposed to be mixed, but I try to be creative and just explore and then find out something where I have days where I need to reach out to my emergency kit and get some medicine out there to manage my symptoms over, maybe it's a challenging period at work. And then after that, I'm back to just using diet and exercise. Yeah.
Wow.
So just be hopeful, and that if you can find the right mix of, therapy, medicine, lifestyle changes, you can at least have a stable condition. Yeah.
Yeah. Wow. So I guess we'll have you on the show again. So later we'll talk about scheduling.
Sure.
I'm very interested in knowing more about the neurologists and any other components and about the AI and stuff like that. I think it will be it will be a very interesting conversation. So thank you so much, Tom. I know you're in a rush also, so I'm going to let you go. On behalf of the community, I would just want to say thank you so much for being so willing to share and being so open about your journey. And we look forward to hearing from you soon.
Okay.
All right. Thank you.
All right.
Thank you. Say bye.
Bye. Bye.